Hello everyone and welcome to my YouTube channel. This is Dr. Naz and today I am going to discuss about tuberculosis. It is the world's leading cause of death from a single infectious disease and it is most commonly caused by Mycobacterium tuberculosis. It is an acid-fast bacillus. The mode of transmission is via inhalation of aerosolized droplets, nuclei from infected patients. So the bacilli are inhaled and lodge in the alveoli. Bacilli then initiate the recruitment of macrophages and lymphocytes. The surviving organisms multiply and disseminate via lymphatics and the bloodstream. The macrophages undergo transformation into epithelioid and Langerhans cells which aggregate with lymphocytes to form the granulomas. So this is the histological picture of Langerhans cells, or also known as giant cell. These are formed by the fusion of epithelioid cells, which are the macrophages basically, and they contain the nuclei which are arranged in the horseshoe-shaped pattern in the cell periphery. They are not specific for tuberculosis, but they are present in tuberculosis. So this is the picture of caseating granuloma. It has a necrotic base and which contains dead bacteria or live bacteria and infected macrophages, then surrounded by macrophages, then it is surrounded by another type of macrophages which is known as epithelioid macrophages, and these epithelioid macrophages are then combined and fused together to form multinucleated giant cell. So the difference between a caseating granuloma and non-caseating granuloma that occurs in sarcoidosis is that in caseating granuloma there is always the presence of necrotic tissue, whereas in non-caseating there will be inflammatory cells only. As I have told you earlier that numerous Langerhans cells will combine to form a granuloma. Then the numerous granulomas will aggregate in the periphery of the lung and they will form Gohan focus, and it is the primary lesion of tuberculosis. Then these Gohan focus will combine along with the enlargement of lymph nodes. They will called as Gohan complex. Ranke's complex is Gohan complex which undergoes fibrosis and calcification. I'll show you pictures in the next slides. Reparative process encases the primary complex in a fibrous capsule, limiting the spread of the bacilli. After the resolution of the primary infection, the organism remains dormant within the granuloma, and any insult to the immune system will result in the activation of TB at any time. So this is the picture of Gohan focus marked with the arrows, which is formed by the fusion of multiple granulomas. And this is the picture of Gohan complex, which is Gohan focus along with enlarged hilar lymph nodes. You can clearly appreciate that the lymph nodes are enlarged, and a Gohan complex can also be seen in this slide. This is Ranke's complex. You can appreciate calcification here. So primary pulmonary TB. It refers to the infection of a previously unaffected individual. It is usually asymptomatic, but if the immune system is incomplete, the pulmonary and constitutional symptoms of the TB may develop. Then it will be known as progressive primary TB. So there may be influenza-like illness, lymphadenopathy, collapse of the lung, and consolidation. They both appear on the right middle lobe. Cavitation, miliary TB, meningitis, and pericarditis may occur. Secondary tuberculosis, also known as active tuberculosis or post-primary tuberculosis. It occurs when the host immunity is weak. Example in HIV, malignancy or diabetes mellitus. It affects the most oxygenated part of the lungs, that is apex of the lungs. And the clinical features may include chronic cough with hemoptysis, low-grade fever, night sweats, weight loss, malaise, and loss of appetite. Spontaneous pneumothorax can also occur in tuberculosis. The presence of miliary pattern and cavitation are the indications of active disease. So what is miliary TB? It refers to acute diffuse dissemination of tuberculous bacillus via bloodstream. So it is basically dissemination of tubercle. Clinical features may include 2 to 3 weeks of fever, night sweats, anorexia, weight loss, and dry cough. Hepatosplenomegaly may also occur. Headache may indicate a coexisting meningitis. Fundoscopy will show choroidal tubercles, and chest X-ray will show millet seed appearance. These are fine 1 to 2 millimeter lesions distributed throughout the lung fields. I'll show you the pictures in the next slide. This is fundoscopy, and you can clearly see choroidal tubercles pointed with an arrow. This is chest X-ray showing millet seed appearance. These are small 1 to 2 millimeter lesions which are distributed throughout the lung fields. So the complications of pulmonary TB may include massive hemoptysis. It can occur due to erosion of any of the pulmonary vessel. Cor pulmonale can also occur, which is right-sided heart failure secondary to any disease in the lung or pulmonary vessels. So here the disease is in the lung, so it will result in right-sided heart failure. Aspergilloma, which is fungal ball infection, it occurs because the immunity is low in a tuberculosis patient and there can be superimposed infection with fungus. Bronchiectasis can also occur, and bronchopleural fistula can also be formed. In non-pulmonary complications, there can be enteritis. It is due to swallowing of the sputum which is infected with bacteria. Anorectal disease can also occur due to swallowing of a sputum. Ponson's polyarthritis is also a complication of pulmonary TB. It is a symmetrical joint inflammation. It usually occurs in young adults, and it is immunological response against tuberculosis. So there will be no bacteria in the joints. The extrapulmonary involvement can occur in the lymph nodes, gastrointestinal tract, pericardial cavity, bones and joints, and central nervous system. We will discuss all these in the coming slides. So for the lymph nodes is the most common extrapulmonary site of the disease, and the most common in the lymph nodes is cervical and mediastinal lymph nodes. The clinical features may include painless lymph node enlargement. Nodes will be mobile initially, then they become mated and can suppurate with sinus formation. The tuberculin test is usually strongly positive. Scrofula can also be formed. It is called massive cervical lymph node enlargement with discharging sinus. The picture is in the next slide. See, these are cervical lymph nodes enlargement, and you can see the suppurative pus which is coming from the sinuses. So in the gastrointestinal tract, the most common site of tuberculosis is ileocecal region, and the main differential will be from Crohn disease. Also you can say that typhoid fever, because there is initially lymphoid enlargement in the typhoid. And the clinical features may include same B symptoms: fever, anorexia, night sweats, and weight loss. Other than this, right iliac fossa mass can be felt on examination. Acute abdomen can also be present in 30% of the cases. Tuberculous peritonitis can also occur, which is characterized by abdominal distension, pain, and constitutional symptoms. A site is exudative with predominance of lymphocytes. Pericardial disease is characterized by pericardial effusion or constrictive pericarditis. So in the pericardial effusion, what happens that the patient might have thickened or calcified pericardium as well. This will lead to dilation of the major blood veins, and it occurs due to backing up of the blood because heart is kind of entrapped. So the heart will be seen as a globular structure on the chest X-ray, and there will be breathlessness and abdominal swelling due to collection of fluid in the abdomen, and fever, night sweats are uncommon. JVP will be raised due to backup of the blood. There will be hepatomegaly due to the same reason, prominent ascites and peripheral edema. Due to fluid around the heart, there will be increased pericardial dullness. In the constrictive pericarditis, breathlessness and abdominal swelling will occur. Fever and night sweats are uncommon. Raised JVP, hepatomegaly, prominent ascites and peripheral edema. Same the reason as in pericardial effusion. The early third heart sound and a pericardial calcification is seen in 25% of cases. The central nervous system, it may cause TB meningitis or tuberculoma, which is a space occupying lesion. I have attached the picture of tuberculoma. You can see multiple tuberculomas in the CT scan. So in bone involvement, when the TB infects the spine, it is known as Pott's disease, and it is the most common side of tuberculosis in the bone. And in the spine, it will mostly affect lower thoracic and lumbar region, and it will distort these regions, result in kyphosis, that is involvement of anterior vertebral bodies. Chronic back pain may also occur because the infection involves the disc, intervertebral disc, and it results in discitis. The sauce abscess may also occur, which is a cold abscess in inguinal region. The main differential diagnosis will be malignancy, but in malignancy there will be involvement of vertebral body in only, and there will be no disc involvement. In joints, the most common site is hip and knee. Ponsets arthropathy can occur. I have discussed this earlier, that it is a reactive arthritis. It involves the joint symmetrically, and it's mostly present in young individual. It is the immunological response against tuberculosis, and in the bones and joints there will be no bacteria present. It starts within 2 months of starting treatment of TB. This is the Pott's disease. You can see the spine, the whitish area is, or hyperdense area is showing Pott's disease. The chest x-ray will show the upper lobe infiltrates with cavitation, which is the classic finding. There can be collapse, calcification, pleural effusion may also be present. The second test which should be done for diagnosis is sputum staining. In this, there will be direct microscopy of sputum, and it is the most important first step. Positive smear is sufficient for presumptive diagnosis of TB. Methods can be using two of the following stain, either Oramine fluorescent test or Zeal-Nelson stain. Zeal-Nelson is less sensitive, but it is used in our area mostly. If patient is not expectorating the sputum, then the sputum can be obtained by using bronchoscopy and lavage, or by induction with nebulized hypertonic saline. Sputum culture, it is required for definitive diagnosis of the TB. So the 3 morning specimens should be collected. The methods can be any one of the following: solid media, which is also known as Lowenstein-Jensen medium, and it takes 4 to 6 weeks. Liquid media, Bactex system, it takes 1 to 3 weeks. And nucleic acid amplification, which is called PCR, it is done more rapidly. And you need to memorize the name of medium because it is also important. So for the diagnosis of extrapulmonary TB, we can perform fluid examination, example CSF, ascitic fluid, pleural fluid or joint, space fluid, and we can perform tissue biopsy from lymph node or bone marrow, and liver biopsy. So the management include initial phase and continuation phase. Initial phase is of 2 months period, and then for the 4 months it is continuation phase. So the 4 drugs are used in initial phase, which are isoniazid, rifampicin, pyrazinamide and ethambutol, and in the continuation phase there will be use of isoniazid and rifampicin only. Extended treatment, which is done for the duration of 9 to 12 months, it is only indicated in one of the following conditions: either the patient is HIV positive, or the tuberculous osteomyelitis is there, or the patient is having biliary TB, meningitis. In meningitis, minimum 12-month treatment is required. In pregnancy, because first line agent pyrazinamide is contraindicated in pregnancy. If drug intolerance occurs and a second line agent is substituted, then you will also go for extended treatment. So these are the first line agents given in tuberculosis. First is isoniazid, and it should always be started with vitamin B6, also known as pyridoxine, to prevent the symptoms of deficiency. Example: peripheral neuropathy, stomatitis, glossitis, chelosis and convulsions. These all can occur due to deficiency of vitamin B6. So when you start isoniazid, vitamin B6 is essential. And the toxicity of isoniazid is seen by hepatitis, peripheral neuropathy, SLE-like syndrome and psychosis. So next is rifampicin. In rifampicin toxicity, there will be orange to red color urine or tears. and hepatitis and thrombocytopenia may also occur. It induces P450 enzyme system, and there will be acute renal shutdown. Orange discoloration is a benign finding and does not need any treatment. Third is ethambutol. So ethambutol involves eye. So it will cause optic neuritis, color blindness for green, decreased visual acuity, and central scotoma. All are the eye involvement symptoms. So if there is any of the symptoms, then you have to reduce the dose or stop the drug. Pyrazinamide, as I've told you earlier, that it is contraindicated in pregnancy. It causes photosensitization, hyperuricemia, gout. Streptomycin involves 8th cranial nerve, which is vestibular nerve. So it is ototoxic drug. Agranulocytosis and nephrotoxicity also occurs. It is used only if the patient has multi-drug resistant TB or not responding to the therapy. Otherwise it is not used, and it should also be avoided in pregnancy. So these therapies are given as directly observed therapy, also known as DOT therapy. And what is DOT therapy? It needs to be given under supervision. So there is supervised administration of antituberculous treatment 3 times per week. It aims to improve adherence, which is a major factor in prolonged illness, risk of relapse, and the emergence of the drug resistance, because it is a very long course. So you need to directly monitor the administration of the drug. So the second line agents includes quinolones, amikacin, kanamycin, captomycin, and cycloserine. So in pericardial TB or tuberculous meningitis, there will be a role of steroids. So steroids should be added along with antituberculous drugs in these 2 conditions. And what is multi-drug resistant TB? It is the TB which is resistant to isoniazid and rifampicin, whereas XDR TB, which is extended drug resistant TB, is resistant to isoniazid, rifampicin, also from second line agent, that is quinolone, and at least one of these 3 second line agents, that is kanamycin, captomycin, and amikacin. Montauk's test, also known as tuberculin test or purified protein derivative PPD skin test. It is not a general screening test for the whole population. However, it is indicated in those individuals who are asymptomatic with latent TB. And PPD is not useful in those who are symptomatic or those with the abnormal chest X-ray. So these patients should have sputum acid fast testing rather than PPD. What is the mechanism of Montauk's test? It is based on the cell-mediated immunity with the development of induration and inflammation at the site of the injection due to infiltration with mainly T lymphocytes. So how do we do it? There will be intradermal injection of 0.1 ml of a 1:1000 strength PPD on the volar aspect of the forearm. Induration but not erythema. That means you have to see the bump, not the reddish discoloration. It is measured after 72 hours of the infection. Positive test is induration of more than 15 millimeter if the patient has no risk factor, and induration of more than 10 millimeter with patients having risk factors. These are positive tests. And what are the risk factors? The prisoner, healthcare worker, close contact of someone with TB, hematological malignancy, alcoholic, diabetes mellitus, and IV drug users. So if these risk factors are present and there is induration of more than 10 millimeter, then it is considered as positive. Induration of more than 5 millimeter is considered positive in HIV positive patient, immunocompromised patients who are taking steroids, example prednisolone, for more than 1 month, close contact with the patient with active disease, abnormal chest X-ray, example showing apical calcifications, organ transplant recipient patients. So in these patients, induration of even more than 5 millimeter is also sufficient to be considered as positive. So this is how the induration is measured in the tuberculin test. So false negative result can also occur in this test. What is false negative result? That is, a disease is present but the test is showing negative result. So in severe TB, 25% of cases may show false negative result. Newborn baby and elderly, because their immunity is low, therefore the T lymphocytes may not collect over that area and may not cause induration. HIV, if CD4 count is less than 200 cell per ml, malnourished patient, and malignancy, these all can cause false negative results. Guidelines: if a patient has positive PPD, a second test is not necessary. If a patient has negative PPD now but has never had PPD skin testing before, a second test is indicated within 1 to 2 weeks. If the second test is negative, it means the patient is truly negative, and if the second test is positive, it means that the first test was false negative. Positive PPD test: the first step after a positive PPD test is to do a chest x-ray. If chest x-ray is positive, then you have to start anti-tuberculous therapy, and if the chest x-ray is negative, then you have to start prophylaxis with isoniazid for 9 months and start prophylaxis with rifampicin for 4 months in cases of isoniazid resistant cases. So BCG vaccine is used for the prevention of tuberculous infection. It is a live attenuated vaccine derived from Mycobacterium bovis. It is administered by intradermal injection and it is highly immunogenic. In children, it prevents disseminated disease and TB meningitis. In adults, its efficacy is unknown. It is, however, a very safe vaccine. What are the contraindications of the vaccine? Because it is live attenuated vaccine, so all the immunosuppressed individuals and the pregnant ladies should avoid this vaccine. I hope you learned something from this video. If you do, please like the video and subscribe to my YouTube channel so that I get motivation to make videos. And thank you so much for watching.